In this episode, I would like to wrap up our discussion of interstitial lung diseases with discussing the prototypical interstitial lung disease, which is idiopathic pulmonary fibrosis, and then discuss some of the general treatment options for all of these interstitial lung diseases. Now, we have 4 idiopathic interstitial lung diseases. We discussed the ones associated with some underlying etiology or secondary types. Please review them. They included pneumoconiosis, the granulomatous type, hypersensitivity pneumonitis associated with environmental organic exposure, and then we had the smoking related conditions. We also have a category of connective tissue disease related interstitial lung diseases that happens on the setting of rheumatoid arthritis, SLE, systemic sclerosis. We will discuss them together with those syndromes separately. And then we have this specific group of conditions which are eosinophilic lung diseases or eosinophilic pneumonias. We will discuss them again in a very brief episode. But this is the 4 idiopathic interstitial lung diseases, including idiopathic pulmonary fibrosis, also known as a usual interstitial pneumonia, as opposed to non-specific interstitial pneumonia. And then we have 2 other conditions which are each other's differential, and those are cryptogenic organizing pneumonia, also known as bronchiolitis obliterans organizing pneumonia, and acute interstitial pneumonia. So, what about interstitial fibrosis? The most important feature we need to pay attention to is that, similar to asbestos-related lung disease, perhaps the only other type of interstitial lung disease that predominantly involves the lower lung fields is IPF, idiopathic pulmonary fibrosis. Now, in the case of asbestos-related pleural plaques or asbestosis, we had the linear densities. Here we have reticular opacities and cobblestoning in the lower lung fields. This is also the pattern we could visualize better in the preferred test for imaging, and that is always in the case of interstitial lung diseases, it is high resolution CT. What's the finding in auscultation? By basilar crackles. What makes the diagnosis from asbestos-related conditions more challenging? The possibility of linear opacities, which are always distributed in a subpleural fashion, similar to what is seen in asbestos pleural plaque. So the best way to differentiate is the fact that this condition is idiopathic and the history does not show any asbestos exposure. The symptoms are the general symptoms of interstitial lung disease, such as exertional dyspnea that progresses over years. One non-specific clue that, if present, could help the diagnosis in favor of idiopathic pulmonary fibrosis, also known as usual interstitial pneumonia, is a lab finding. What is it? Presence of anti-nuclear antibody or rheumatoid factor. Put it simple, you have a patient with interstitial lung disease pattern of pulmonary function test with dyspnea and involvement of lower lung fields. If the patient has exposure that is asbestos related, if he does not have but instead has ANA or rheumatoid factor, that's idiopathic pulmonary fibrosis. Now, regarding the prognosis and treatment, what's the treatment options? Remember, the prognosis is not very promising. The treatment usually does not respond to immune suppressants, and the most important group of drugs used include the anti-fibrosis drugs such as nintedanib and pirfenidone. Their real effect is just slowing the worsening or progression of the disease. That's rate of decline in pulmonary function test could be slowed by these anti-fibrosis drugs. Now, we have another interstitial pneumonia, and that is non-specific interstitial pneumonia, and therefore that's a differential of usual interstitial pneumonia, also known as idiopathic pulmonary fibrosis. What are the hallmarks of it? It is not necessarily idiopathic. There are some underlying conditions such as connective tissue diseases, hypersensitivity pneumonitis, or even drug-induced causes of interstitial lung diseases. Also, symptoms are similar. So how do we differentiate these two? Not only the risk factors are present in unspecific or non-specific interstitial pneumonia, but very important is the fact that chest x-ray shows ground glass appearance as opposed to IPF that we had subpleural linear or reticulonodular, more commonly as opacities on the lower lung fields. Here in the non-specific interstitial pneumonia, we have ground glass appearance, and also the worsening to the final stage, the honeycombing with progressive massive fibrosis is not so common, and the reason is because we have good response to immunosuppressants and corticosteroids in the case of non-specific interstitial pneumonia. If you're asked immunologically what is the important mediator of pulmonary fibrosis in most of these interstitial lung diseases, what is the immunologic modulator? The mediator is TGF-beta. Its level is usually increased compared to its inhibitors, such as caveolin. Now, if you are asked what is the common, usually end-stage X-ray or high-resolution CT finding in these pulmonary fibrosing conditions, remember we have two terms. One is pleural cobblestoning, that is presence of scar in interlobular spaces, and then we have honeycombing. Remember, both of these features are absent in non-specific interstitial pneumonia, but they are present especially in the later stages of idiopathic pulmonary fibrosis. Are these findings specific? As I said several times, they are not, and most of them could be identified on the final stage of many interstitial lung diseases. So you need to pay attention to the entire picture, including environmental exposure, pneumoconiosis risk, etc. Now, we have two final, very difficult names of these interstitial lung diseases, and one is cryptogenic organizing pneumonia. Don't confuse it with desquamative interstitial pneumonia caused by the smoking. And the other name for this condition is cryptogenic organizing pneumonia. The other name is bronchiolitis obliterans associated organizing pneumonia. Don't confuse it again with respiratory bronchiolitis, also known as desquamative interstitial pneumonia, which is a smoking-related interstitial lung disease. These names, cryptogenic organizing pneumonia or bronchiolitis obliterans organizing pneumonia, similar to idiopathic pulmonary fibrosis and non-specific idiopathic pneumonia, are examples of idiopathic interstitial lung diseases. So what is the hallmark of BOOP, the bronchiolitis obliterans organizing pneumonia, also known as cryptogenic organizing pneumonia? Well, the name is self-explanatory. Organizing pneumonia refers to a fibrosis process that fills the airspace. And bronchiolitis obliterans means this process of fibrosis obliterates the small airways, the bronchioles. So simply bronchiolitis obliterans organizing pneumonia. So what you expect to see in the biopsy? The biopsy would just report to you a accumulation of fibroblasts in small airways. This is called Masson bodies. This is the hallmark of this organizing pneumonia, the BOOP or bronchiolitis obliterans organizing pneumonia. Now, very important risk factor, if just one thing you remember for the risk factors of this condition, is it is seen in transplant patients, specifically those with bone marrow transplant who contract graft versus host disease. Put it simple, a restrictive lung pattern in a patient after bone marrow transplant is BOOP unless proven otherwise. And final condition of interstitial lung diseases is acute interstitial pneumonia. What's the specific finding of it? If you have a restrictive pattern lung disease that has acute onset, all the other conditions have usually a very chronic progression, but acute interstitial pneumonia, as the name indicates, has acute onset of this symptoms such as dyspnea on exertion, and the respiratory function test shows the restrictive pattern. Now, what is the chest X-ray imaging in these two conditions, in both bronchiolitis obliterans organizing pneumonia, also known as cryptogenic organizing pneumonia, as well as acute interstitial pneumonia? Similar to non-specific idiopathic interstitial pneumonia, we have ground glass appearance. However, because these two last conditions are also pneumonias, we could have consolidations and patchy infiltrates. So, put simple, differential diagnosis of ground glass appearance in restrictive lung disease includes non-specific interstitial pneumonia, bronchiolitis obliterans organizing pneumonia after transplant, and acute interstitial pneumonia if acute onset. What is the prognosis of acute interstitial pneumonia? Well, it's a restrictive lung disease, and they usually get into a end stage of cobblestoning and massive fibrosis. If it is an acute process, that means it's going to have a very poor prognosis. Most patients usually require mechanical ventilation, and the condition has high mortality, unfortunately. This brings us to a final discussion of these interstitial lung diseases, and I would like just to wrap up the general symptom manifestations and step-up treatment options. Remember, most of these conditions, regardless of primary or secondary types, manifest with some progressive dyspnea on exertion, dry cough, inspiratory crackle, and very important is possibility of clubbing. If you ask what symptoms are possible at the later stages of disease, while radiologically we expect those findings associated with progressive massive fibrosis such as pleural cobblestoning and honeycombing, in terms of symptoms we are dealing with the manifestations of pulmonary hypertension as well as cor pulmonale, which is simply right-sided heart failure symptoms due to lung disease. Things such as JVD, organomegaly, ascites, right ventricular retrosternal heave, etc. This in physical exam would also show with a loud P2 indicating possible pulmonary hypertension. However, this also reminds us that all patients in the advanced stage require assessment for pulmonary hypertension, possible need for catheterization or echo. What's usually the first test for all of these interstitial lung diseases? Usually the first test is the chest X-ray that shows some levels of reticulonodular interstitial opacities. Next best test is high resolution CT. We would observe honeycombing and traction bronchiectasis in the advanced forms compatible with progressive massive fibrosis. And always remember that the diagnosis of any of these conditions require biopsy. The preferred approach is video-assisted thoracoscopic surgical biopsy. Now, remember, if there is any contraindication to biopsy, that is presence of progressive massive fibrosis and diffuse honeycombing. That's the end stage. Is it possible that we defer the biopsy if for certain conditions such as idiopathic pulmonary fibrosis, where we have very well established CT criteria, if the clinical picture and CT criteria is typical, we may avoid biopsy. About the management for the secondary types, if they are smoking related or in the case of hypersensitivity pneumonitis, we try to avoid these exposures. Most of these conditions are also, if symptomatic and require treatment, would be responsive to corticosteroids, and if not responsive, initially we can upscale to other immunomodulators such as azathioprine or TNF inhibitors. Do you remember any exception that we just discussed that is not responsive to immunomodulators and corticosteroids? That's idiopathic pulmonary fibrosis, against which we use anti-fibrosis agents. Many of these conditions, similar to obstructive lung disease, are associated with smoking, and therefore all patients would benefit from smoking cessation. Theoretically speaking, however, one of the conditions would not necessarily benefit from smoking cessation, and it's because it's shown that smoking could have preventive role for that or slow the progression, and that is hypersensitivity pneumonitis. Regarding the assessment in the advanced stages, always remember that patients need workup for diagnosis and management of pulmonary hypertension. And if the PaO2 drops to values less than 55 millimeter mercury, we begin oxygen supplementation and pulmonary rehab regimens. Now the question is, what group of patients are the candidates for lung transplant in the setting of advanced interstitial lung diseases? The answer is the young patients with end-stage interstitial lung disease. And this finishes our discussion of interstitial lung diseases.